Hi, it's Tom here from Running Physio. Today I want to talk to you about Achilles tendon ruptures and the rehab process, taking them from the very early stages back to return to running. Now, I have had quite a few questions about this recently, particularly people emailing me about how do you get people back to running with this particular injury. So I thought I'd delve into it, explore some of the protocols that are out there, and what we can do to try and successfully get people back to running the sport that they really love. I've also included links to our free videos over on Clinical Edge. We've got great videos there, including a really cracking series on iliotibial band syndrome. So do check those out. Now, I will say from the start, I'm not an expert in Achilles ruptures. I see lots and lots of tendinopathy predominantly, but I'm not seeing hundreds of people post Achilles ruptures. So this was an area I felt I needed to really kind of learn more about before I could share some of what I've learned with you. So I just want to be honest about that from the start. There are some brilliant experts out there like Karen Silbernagel who've published extensively in this area, so I would highly recommend looking into their work. But what I've done is I've gone and had a look at some of the most recent research. I've thought about some of the key things that we can then talk about in this video. But if you've got different ideas, different opinions, let us know in the comments and replies afterwards. I've learned quite a lot, so hopefully I can pass on some of that knowledge to you. So first up, the patient presents then typically in A&E with Achilles rupture. They might have that typical history. They report like they've been kicked or shot in the back of the leg whilst they've been loading that calf, typically in a stretched position. It's often male patients, perhaps into their 50s, that seem to be the at-risk group. So are we going to go first for a conservative approach for this patient or a surgical approach? Now, looking through the research, it seems that this is still a bit of a controversial topic. There seems to be some debate around it. But on the whole, from what I was able to find, it seems the results are going to be fairly similar with conservative versus surgical approach. Now, one group that does seem to go for surgery more option is elite athletes. For the most part, in the evidence I found there, they will tend to go for surgery because they think it's likely to lead to better strength outcomes further down the line. So elite athletes, and most of the evidence in that group, tends to focus on surgery rather than conservative approaches. Now, the surgical approach does come with risks. There are more likely to be wound complications, infections, etc., potentially local nerve damage and things as well. So that is something to bear in mind. But for a lot of recreational athletes, a lot of people, they will do quite well with a conservative approach. So there doesn't seem to be a clear winner between the two there. It depends on the patient and their needs at the end of the day. One thing that also I found came out quite clearly in the research is that early mobilization following Achilles rupture seems to be really beneficial. It may help to reduce muscle atrophy and stiffness and stimulate tendon healing. It may also help to reduce the risk of things like DVTs potentially. So the newer protocols are looking to encourage early weight bearing as soon as possible. And this is good. Certainly when I first qualified, a lot of the Achilles rupture protocols were very conservative with restricted weight bearing in the early phases. And I think that probably prolonged the recovery process. Now, as I said, there are a number of different protocols out there. And I haven't found one that I would say this is what we recommend to everyone. And I'd certainly say if you're working with patients with this, think about their individual needs. Think about the local, perhaps sort of trust protocols or the protocols from the orthopedic surgeons you might be working with, rather than following any of these things as a recipe. And certainly if you're a patient listening in, please don't follow these as a recipe and assume it's going to be right for you to do all these things at these time scales. This is just a kind of standard protocols that are out there. So one that I particularly liked, which was a conservative approach and that encouraged this early weight bearing, was a protocol just published by NASCAR et al. In foot and ankle. Now, as I said, this is a conservative approach rather than a surgical approach, and they start, right at the beginning by putting the patient in an orthosis in a vacuped boot. which allows them then to start weight bearing right at the beginning of this process. And that boot is then fixed on 30 degrees with a wedge sole. So for the first couple of weeks, we're obviously limiting any loading into dorsiflexion, and then weight bearing as pain allows in this orthopedic boot. Now, as you can see, as we progress through the protocol, first 3 or 4 weeks is going to be fixed, the boot fixed at about 30 degrees with the wedge sole. Then we can start to change the range from week 5 and 6 onwards. So the range of movements now between 15 and 30 degrees, and continuing to weight bear as tolerated. Week 7 to 8, we can increase that range now 0 to 30 degrees and with a flat sole. And then from week 9 in this particular protocol, we can start using personal footwear indoors, but using the boot outdoors. Now, with this, early phases, it's likely the person's going to be on crutches to help them with this weight bearing. So it's weight bearing is tolerated, typically supported by crutches. Then from week 10 onwards, they're out of that boot, and they're gradually getting back into activities like swimming, walking, cycling, and continuing their physiotherapy. So this is quite a nice sort of 12-week protocol, conservative approach, using this Vacoped boot to allow weight bearing from the early stages, and then gradually changing the range of movement through which the Achilles is being loaded, gradually exposing it to a little bit more in terms of dorsiflexion. And that seems to be what a lot of these protocols do in varying different ways. They start in a more plantar flex position and they gradually increase that range to them. Now, what I also really liked about this protocol is that right from the early stages, physio features and exercises feature. Now, I've adapted some of their recommendations here then. So from week 1, they're encouraging active toe movements alongside limb elevation to try and reduce any swelling, which we know we do get after Achilles tendon ruptures. From week 3 and 4, they're encouraging people to start quads, hamstrings, and gluteal strengthening. Now, there's lots of exercises that you can do in non-weight bearing positions or in positions that don't load the calf and ankle to target these muscles. We know they're so vital in sport, and if our weight bearing is restricted, they're likely to weaken. So I really like that they bring this in early in the protocol, get those muscles nice and strong, and keep them strong so that when we're coming back into sport, they're ready for it. Week 5 and 6, we're now looking at trying to restore a bit more range of movement to facilitate the weight bearing. So encouraging people to do active plantar flexion and dorsiflexion, but in the boot, because that's going to limit the range that they go through. From week 7 to 8, we're now getting people to do active plantar flexion and dorsiflexion out of the boot, but not beyond plantar grade. We really don't want to be stretching this tendon. In fact, some studies suggest no stretching for 6 months post Achilles rupture, because we don't want elongation of the tendon that's going to affect its function. And here in this NASCAR tool protocol, they're starting isometric ankle strengthening within the boot at week 7 and 8. Then by week 9, we can start to do some isotonic ankle strengthening, so ankle dorsiflexion, plantar flexion, inversion and eversion, perhaps with some resistance band, starting to introduce low levels of load to restore strength. From week 10 onward, where the person potentially now coming out of their boot, we can be doing some proprioceptive work and some single leg balance, maybe some unstable surface or wobble board work, and start to introduce more ankle strengthening, such as seated double leg calf raises, more leg work like wall slides, and actually trying to encourage people to return to a full active range of movement at the ankle. And as we said in the earlier slide, trying to get them to return to some normal function that tends to have relatively low load on the Achilles. Now, what I found doing my research, reading around some of these protocols and the published research, is that a lot of these protocols seem to stop now. So they guide you up to maybe week 10 to 12, and then they go a bit quiet. There doesn't seem to be much specific advice on how to take people from week 12 onwards in the studies that I've seen. Now, there are lots of studies out there, so possible, likely even that I've missed some. So perhaps if you know of more comprehensive protocols, let us know. But a lot of them seem to stop at that point. And for me, this doesn't prepare people for the needs of their sport. And we know long term after Achilles ruptures, there's likely to be deficits in strength, in muscle bulk, in power, that they aren't going to be resolved with the management that's in this protocol so far. So I had a bit of a think and a look around the research at, well, what would we do next? What would be the next steps from it? And this is what I put together based on some research from Lurch et al. And Tarantino et al. And experience in this area. So as we progress then from week 12 up to around about week 16, and please again see these timescales as rough estimates that will need to vary based on your patient, we want to try and progressively strengthen that calf. So important to restore the strength and restore the muscle bulk there. So this might start with seated calf raises, then progress onto double leg calf raises, and then single leg by approximately the 16-week stage. That was a figure suggested by Lurch et al. We may also want to increase the demands from function, so increasing walking speed or distance as tolerated, thinking about other activities to build fitness such as cross training, rowing, incline walking, going up and down stairs, etc. But of course, it's all got to depend on the patient's goals and needs and where they are at this phase. I've known some patients at 16 weeks still be on crutches, still partially weight bearing, so it would not be appropriate for them to be pushing into something like the cross trainer or trying to build up their walking speed just yet. So we want to restore normal walking, normal comfortable activities before we progress. Then from week 16 to roughly week 20, if the patient's managing well, if you feel they've achieved their strength targets and it's appropriate for them, we might start to reintroduce some light plyometrics, perhaps starting with some easy double leg work, and then progress to include more challenging plyometrics, low speed running, and eventually hopping. As you'll see in a moment when we look at tendon loads, as we go up towards single leg impact work, the load on the tendon increases really significantly. When they're managing low plyometrics and some low speed running, we might want to think about sport specific drills such as change of direction, roughly in this time scale, but there will be a lot of variety out there. Now, Tarantino et al. Suggests that some people may be able to return to non-contact sport as early as 16 weeks and contact sport as early as 20 weeks after an Achilles rupture. But they also say that this isn't based on a lot of evidence. There's not a lot of studies to actually show that. But this may be, in theory, the time that some sporting activity can be started, but it will massively depend on the patient and the return to sport testing that you may choose to do. And we'll have a look at that shortly. And then Lurch et al. Suggests that people should be aiming for a full return to all sporting activities by roughly the 6 months stage. So hopefully people are returning to their sport, but looking at the studies, you see quite a variety in the studies. Some suggest roughly 80% will return to their sport, but that may not necessarily be their pre-injury level of sport. The powerful actions that we really need the Achilles for are difficult to restore. So hopefully we can see there in the early stages, we've got to respect the healing. We've got to consider the individual needs. In the latter stages, if the healing is progressing well and the patient's ready for it and it's safe to do so, we really want to progress on, particularly with returning the calf strength and bulk. Very, very important. That can then facilitate us to bring in some plyometrics. Now, one of the studies that I thought was quite useful to share with you is Baxter et al. That's looked at peak Achilles loads during various activities. And I've adapted some of their findings here. Now, they divide these activities into these 4 different tiers. So tier 1 being the lowest peak load on the Achilles and tier 4 being the highest. So we could, as we're trying to progress people with their function and their rehab, gently work them up through these tiers, obviously choosing the right timescale and based on their symptoms. So things like seated heel raise, for example, was around about 0.5 times body weight in peak Achilles load. But the forward hop on single leg and lateral hop on single leg, tier 4 activities, were 7.3 times body weight in peak load. So you can see there's quite a scale from the bottom to the top here. So perhaps in the early stages, we're starting with tier 1 activities, such as a seated calf raise, possibly squat. Then we're going into tier 2 activities where we can start to introduce things like perhaps lunging, perhaps increasing walking, looking at step ups and step downs, and then if it's appropriate, progressing on to some light plyometrics like 2-leg forward jumps, and ultimately at the right time scale getting onto standing heel raises on single leg. And then as they're progressing on, typically perhaps around about roughly that 16-week mark perhaps, we would be looking at trying to bring in more of these plyometric activities. So perhaps starting with double leg stuff like drop jumps and two-legged hops. Thinking about introducing slow speed running, and then maybe looking at progressing on to counter movement jumps or forward jumps potentially. And then in the latter stages, we're getting towards your single leg stuff. So single leg drop jumps, lateral hops, forward hops, etc., as a way of progressing someone through and gradually exposing the tendon to higher and higher peak loads. Now, we do see a lot of variety in our patients in terms of what they can tolerate. I think it massively is influenced by what's done in the early stages of the rehab. I saw a gentleman recently, as I said, who was still on crutches at 16 weeks, and it was because there was very little loading in the early stages. So at the 16-week point, he wasn't able to even initiate a single leg calf raise. We were still very much on double leg calf raise work and just trying to restore the strength in the calf through that before gradually increasing the load and gradually placing more stress towards that injured side. So really is going to be individual specific, but certain characteristics for each individual is going to make a difference too, such as age, such as body mass index perhaps. If you have someone with a very high BMI, that may well affect their recovery. Things like diabetes may affect the healing as well if they've had surgery and they've had wound infection or anything else like that. So it's so important with these protocols just to see them as a rough idea and to adapt based on the individual, with safety really being the priority here with these. Now, my interest then obviously is getting people back to running. And I was looking through the research whether there was some really nice, clear guidance that I could share with you in terms of what are the criteria for someone to return to running. And I found very little, to be honest. What I did find in one paper from Hansen et al. Is this. Now, they say at 16 weeks, running on soft, even surfaces can be started slowly if the participants can walk 5 meters on tiptoe and perform 5 consecutive single heel rises on the injured leg at 90% of the height of the uninjured leg. So this was one of the few things that actually provided some guidance here. So we've got the time scale there. They're suggesting 16 weeks. They're giving us an idea of what we're starting with. So running slowly, potentially on soft surfaces, and they want to see there's some reasonable calf function here. So you can tiptoe walk 5 meters and you can do 5 consecutive single leg heel rises with 90% of the range of the other leg. So that gives us something to go on. But I haven't found any research that's actually shown whether this correlates with, say, re-injury rates or re-rupture rates, or whether that seems to help. I wonder if certainly with some patients, at-risk individuals, we may need to be a little bit more thorough with our return to run testing. So here's some ideas I had with potential criteria for return to running after Achilles rupture. So timescale, I do think around about the 16-week phase seems to be sensible depending on the patient. I'd like them to have non-irritable symptoms, so no pain with ADLs, activities of daily living. So they should be pretty comfortable with day-to-day activity. They should have good load tolerance, so they can walk without any limp or restriction for at least 30 minutes before we're going to get them back into running. Now, calf strength, you can see with that previous quote that they suggested just 5 single leg calf raises was enough. I'd like that calf raise capacity, so reps of fatigue, to be maybe 70 to 80% on the limb symmetry index. So 70 to 80% of your good side, essentially. Now, I'm not going to be rigidly strict on that, but I think we do want the calf to be functioning well if we're thinking about long-term tendon health. Remember, these are people coming in quite often with degenerate tendon already, so we want to have them, give them the best chance of a successful return to sport. In terms of range, I think restoring dorsiflexion range is important, although we don't want to be aggressively stretching, because if they're very, very tight into dorsiflexion and their sport stretches them into that position, I wonder if that's going to increase that risk of re-rupture. So again, I might be looking at about 80% on the limb symmetry index, so 80% of the range of their good side. But for running, I really want at least about 25 degrees. Now, my reasoning here is that peak ankle dorsiflexion in running is typically roughly 20 to 25 degrees. So we need to get into that range in order to run. So you may choose when they're doing their return to running to watch them run and see, do they feel comfortable? Does their running gait look similar left versus right? If they're trying to shorten their stance phase, if they're switching to a forefoot strike on that side, perhaps if there's early heel lift, perhaps it might be a little bit too early to introduce running for them. And then because running is a plyometric activity, we want to see they've got some plyometric ability. So I want to see they can jog on the spot for 1 minute without any symptoms. They can bound 10 times on each leg, hop 10 times on each leg as well, comfortably. And then we're going to start them with a test run. Now, my test runs usually are around about 3 to 5 minutes. They're nice and short, but we want to then see how they respond to it. Are they getting pain during or after the run? Do they get a big swelling response? Are they getting discomfort elsewhere in their body? If so, we may need to back off. But if they're comfortable during the run and any symptoms are mild and settle quickly, we may then continue to progress them through that return to running program. Now, thinking about Achilles load, it is likely to increase with faster running, and it's likely to increase with hill running. So typically, if someone's managing those test runs, we're going to start by building the training distance first, maybe 3 runs a week, and gradually building up to about half an hour, so 3 runs of about 30 minutes. Once we've got them up to that point, that's the time we might start to think about introducing some slightly faster runs, so some medium intensity runs like steady state or tempo runs, and then eventually taking them on to interval work to restore higher intensity running. And towards the end stage, we might introduce more hill running, starting slow, and things like hill sprints, if they really want to do them, are going to be the last thing on the list when we feel they've got good plyometric ability, good range, good strength, and they've progressed through that tendon loading process with their running and everything else. So we're going to gradually get them back to where they want to be. Now, sometimes people find restoring their training speed difficult if they haven't got adequate power. And this isn't just true of tendon ruptures, it seems to be true in tendinopathy as well. So if they're getting symptoms or they're finding it hard when they're increasing their speed, we may want to focus more on restoring that power. And that's another key point really from this. The rehab doesn't stop when they return to their sport. That rehab needs to continue. And I would say these are similar to your ACL surgery patients in that you may well be looking at continuing some form of rehab 9 to 12 months, after their initial injury to ensure they're getting back to the level they want to be. We think a lot of the improvements you're going to get in calf strength and function are probably going to happen in that first 12 months. So I'd really try and utilize that window to get them as good as you can do. So yes, you might have got them back to running, but can we really push that calf strength on by adding external load? Can we get the volume right in terms of our exercise prescription to restore the muscle bulk? So we're aiming at kind of hypertrophy levels in some of the exercises. Can we progress them on through with their plyometrics to really try and get that power back? And think about what the calf and Achilles need to do there. The calf needs to help us both with vertical forces and horizontal forces. It needs to produce adequate stiffness around the ankle, so we may bias our exercises towards doing that. So we might have exercises more focused on vertical forces like jump squats or single leg hops in place. We might have exercises more biased around horizontal forces like forward bounding or repeated forward hops, or exercises designed more for stiffness, such as getting people to jog on the spot and stop the heel from dropping at all each time they land on their toes. So they're getting this very nice stiff calf complex. But as I've said throughout this, it all needs to be introduced at the right time for each individual because there is this re-rupture risk. Now, reading around the research, that the time scale for that for re-ruptures seem to vary anywhere from roughly 8 to 16 weeks ish from what I've read, with the average being around about 9 weeks in one particular paper. So we know in that phase of the rehab that seems to be a particular time perhaps where rupture is more likely. So that's going to be the time we're going to be more cautious. We're going to wait till the appropriate point of healing before we're going to really progress on with the rehab. Okay, so hopefully that gives you some ideas. I'm going to put the key references here in the comments afterwards, because there's some cracking papers here actually that you can go and have a little look at. Maybe you're someone who's seeing a lot of these and you'd like to look at some of these papers. So I'll put those in the comments for you shortly afterwards. As I said, so anyone listening in, this is not a recipe. We do need to be careful and think about individual needs, but hopefully it'll give you some ideas about early, mid-stage and late-stage rehab, some criteria that you could consider for return to running and adapt to the individual and their risk assessment, and how you might then progress on their running as well. Okay, thanks again for listening. Bye for now.